I do want to show you some things about Lampoon concepts, because actually of all the things, this is one that still confuses people probably the most of these procedures. And the other thing I want to tell you is, so I've had the honor of being helped bring three sort of novel techniques to everybody, right? Transcaval, Lampoon, and Basilica. And interestingly, of those three, we have now heard of more failures of Lampoon and Basilica than actually all transcaval. All kidding aside, there's been like one failed transcaval in the entire world, like out of 600 cases, and there's cropping up failures, and I think it's because people don't understand quite all the concepts. And I think everybody understands that there's an LVOT obstruction risk here, right? It's all fun and games until this happens to you and the patient dies. And everybody understands that it's a flow issue, right? This is flow, right? The pink here is what's inside the chamber when you put that sapien valve in. Sometimes there's simply not enough room, right? But there's also another issue that people don't understand, which is independent of flow, and that is that the leaflet can be an issue. These long redundant leaflets cause problem. They cause SAM. They cause all sorts of issues here, right? And the surgeons don't have those leaflets there. Now, techniques, I don't know why that one picture's not there, but here are your options to prevent that, right? So this is what is being thrown out there, right? You can do a preparatory alcohol septal ablation, meaning you modify the LVOT diameter itself, right? Or you can try and reorient the transcatheter valve, and there are two ways to do that, right? I've done pull A, and then you can put a balloon in there to try and orient the valve away from the LVOT. And then, of course, you can just resect the leaflets, or you can do this Lampoon thing. Now, I have done all of these, just so you know, so if you want to know my opinion about all of them, I'm happy to tell you afterwards. So here's the Lampoon thing, right? What people don't understand here is you need two retrograde catheters, right? You have to burn from under the leaflet through the base of the leaflet at A2. So you need to use transcatheter electrosurgery. All the snare does, it's not necessarily a target. The echo tells you where to go, but you do need to grab it to create the loop, right? This is the exact same thing that's done in Basilica also. This is just the anterior leaflet of the mitral valve. And now you need to electrify the side of the wire, right? First you had to electrify the tip. Now you have to electrify the side because you're going to slice from base to leaflet. Is everybody clear on that? So the failure, so here's a very first case done. I flew down to Emory, and my good friend Vasilis, now my partner, we did the very first one in May of 2016, and then a couple of days later, my patient was lined up, and we came back to Ford, and this is the very first case that I did at Ford, #2 in the world. Here's what it looks like. You just need the LVOT view, right? And you need to just electrify and burn through. You'll see bubbles in the left atrium. This happened to be a patient with a ring, so you can see the rings are great because you got good landmarks, and that's where, it doesn't even matter where the snare is. The snare is just to grab it later, okay? Now, one quick concept about Lampoon is there were about 3 cases we did early on that still failed, and we couldn't figure out why until Gafoor actually it was Melissa Fusari actually from Edwards who said, well, the ventricle is so small that actually the skirt of the valve itself is obstructive because there's 12, 11, 12, 13 millimeters of skirt, right? And if all of that's in the ventricle, you split the leaflet and now you just put skirt there. So we developed this concept called the skirt neo-LVOT. So if you're going to do this procedure, what we do is we put a virtual valve in there, we measure the neo-LVOT, and then we have made a virtual valve that's only 12 millimeters. And we put it at 80/20, and we say, okay, what's the neo-LVOT here? Because you can't correct that at all. Does that make sense? So if you ask me to do a CT for you, you're going to get 3 measurements. You get a neo-LVOT, you get a skirt neo-LV2, and then you get a bailout neo-LVOT, which is a whole other issue, which is what if you screw up and the whole thing's back in the atrium? Can you put another one in? Because if you do Lampoon, right, and you put a valve inside a valve, now the leaflets of the transcatheter valve are your original problem. So we say if your neo-LVOT is less than 150, you're in trouble, but your skirt neo-LVOT has to be greater than 150 to do the procedure. Is that a clear concept? Okay. This is what it looks like when the wire goes through the base of the leaflet from the surgeon's view. Okay? This is the secret of the procedure. It's called the Flying V. For those of you who don't know, it was a famous Gibson guitar made in the 50s. Famously a psychedelic version played by Jimi Hendrix, so he gets credit as the most famous person to play it, but many guitar players use this. But to get the wire to electrify out the side, this is a bath showing that you can do it, you need to denude a little bit of the wire and kink it so that the denuded part is on the lesser curvature of the wire, because electricity wants to go at the greater curve, right? Think about it. If you bend a wire, the electricity wants to go straight. So if you do it and make the flying V correctly, it's a very easy pull. But you have to know that that's the secret. You have to create the flying V. So here's what it looks like. Here's the pull, and here's what the split looks like. These people do well hemodynamically because the leaflets still coapt normally as they do in the aortic position. And this is what the V-gram would look like after the one, didn't do a V-gram on the first patient, so this is actually the second patient I did, a number 3 in the world. The valve can be completely across touching the septum, and flow will now go through it. This patient clearly would have obstructed had there not been. And here you'll see on the LVOT view from TEE, you will see the cage coming all the way across, but you will see flow through the cage. So I wanted to spend some time on the intricacies of why people are failing, and I think it's because they're not asking for help and they don't understand the subtle things that you need to do to get the procedure done. There's been over 60 cases done now. The 30-patient IDE is completed. We'll hopefully reveal the 30-day results at TCT. 2 other quick things. Failed Alfieri stitch and a ring with severe MR. We have modified LAMPOON so that you can split this leaflet. Now, this is an easier procedure. It's the same exact thing, but you don't have to burn through the base of the leaflet. Just go through one orifice, split to the other, get rid of the Alfieri stitch, and now put your valve in. This has been published called Elastic, and we know that it works for mitral clips also. So you could potentially remove any clip. It's going to stay on the posterior leaflet. Just move it off the anterior leaflet. Now you have an SLDA and put your valve in. There's another thing that happens even with these transcatheter valves for the future. Tendyne has this problem where sometimes the leaflet doesn't cause LV obstruction, but there's dynamic SAM from the leaflet. So done in an animal, there's an animal model that you can do in pigs and then actually done in a human as well. So you can use LAMPOON even with transcatheter valves to handle some of these issues. I think it's a more elegant solution than alcohol septal ablation. It's all one procedure. No delay. It can handle, we've done neo-LVOTs that are less than 0. So it's doable. It doesn't appear to affect valve stability, increase PVL, stroke risk, and can be done with Alfieri stitch, potentially mitral clips, but you need to ask for help. You need to come watch cases. You need to understand the subtleties of the flying V. We inject dextrose so that we get the salt away from the wire so that it burns, so the 2 catheters are hooked up to glucose at the time. So there's a couple things that you can't see when you look at the YouTube video, and I think that's why people are failing. So happy to answer any questions about the specifics of the procedure after, but that is LAMPOON in a nutshell. Thanks.
Adam, obviously you've been one of the main people that has really put this whole thing forward. What are if somebody's thinking about trying their first LAMPOON, the most common questions that people ask you that are not in this YouTube video and not in this presentation, what are the other 2 or 3 things you really want to make sure from patient selection, from planning, from even just setup of the lab? Is there anything else that are the top 3, 4 things that you also want to add in the next 20 seconds?
So things I failed to mention for the procedures, we create an AV loop, right? So basically you go transseptal through the mitral valve and out the aortic valve, and you grab it and you snare it. The reason for that AV loops is so you have a rail so that your retrograde catheter that has to go up in the LA for the snare, if it falls back, you can just easily go in and out. But what's key about that loop that you create is you need to be in the center of the mitral valve, not under any cords when you come out. So there are some maneuvers we do to make sure that that's free, because otherwise when you lasso, if you lasso around a cord, right, you're going to rip the pat muscle the cords and you're going to have severe MR, and the patient may not tolerate that part of it, right? So there are some subtle things that you need to do that have all been worked out. The similar things have been worked out with Basilica. The overall technique, right, Basilica is a modification of LAMPOON, so the flying V and the catheters, and that's all the same, but there are some subtle things that we do to prevent mishaps in that as well. And so all I'm saying is come to Emory, watch a case, come to Seattle, watch a case, and have somebody there to help you, because these are incredible techniques to handle real problems. I do think Basilica is the future. I don't know why we're not splitting every valve before we put one in, because no surgeon leaves any valves behind. So let's just throw that out there and say, if it was a 5-minute procedure as part of your TAVR, you would just do it, right? So But I don't want people to fail, and I don't want people to say these techniques don't work, because they do. You just have to know how to do them. Fair enough, Danny? Let's do it all. Let's get it out of the way. Anyway,
So bottom line is ask for help, yes?
ask for help.
Okay. Thank you very much.